My name's Jill Werflinger. I'm the Director of Community Services, and I came on board to join you at the very end of July. I don't need to tell you in the brigade, it's been a really exciting time with a lot of developments, a lot of things going on. And Drew Bennett and I thought that we knew what December was going to look like. And then on December 9th, we got a phone call from Health Emergency BC. And it was a very unique phone call. And it was a phone call that actually told us a lot about the role and the perception of St. John Ambulance's role in the community. Because Health Emergency BC called us to say, we don't need to tell you folks that we're in the middle of an overdose crisis, and we're looking for help, and we thought about you. And it was a really unique opportunity because we didn't have to overcome a problem of, should we do this? That wasn't never a question. Many of you have been coming to us with your desire to make a contribution in this area and to help. And really the biggest problem, two problems we had to overcome, was naloxone training, Narcan training, and national insurance. And this presented us with a really unique opportunity because we'd been trying to make some inroads at the national level with community services and the national management team for a while, but we had an opportunity to help, and we did that. And to kind of skip to the ending, the middle part is really worth sticking around for, okay? So don't hang up in the next 5 minutes. But to skip to the ending, I want to tell you something really exciting that we haven't shared yet, and that is that last Thursday, the national management team met. And after I had the opportunity to work very closely with the National Director of Community Services, he put forward a proposal, a brief, which was unanimously accepted by the National Management team regarding naloxone training and regarding our members delivering those people who've been appropriately trained in the right situation and acting in the right situations are now insured to administer naloxone to those people who require it. It was moving a mountain, people, because this was something we had wanted to accomplish for a long time. And because of your hard work, because of your dedication, because of your passion and your commitment to this pilot that we ran for 4 weeks, we've moved a mountain and we've made that possible for people all the way across Canada. So that's super excited, and I'm giving everybody a virtual high five and pat on the back and saying that's something we can be very, very proud of here in British Columbia. So the problem, as it was presented to us, was quite interesting. And they said, well, we would like you to do this, but here's a sliding scale of what you can do. So we determined right away what our philosophy was going to be, and that is that we are involved in areas and situations in which we add capacity. We are not taking on full management of any particular site. We join what's already happening there, and we add capacity, bench strength, however you want to describe it, and that's the contribution that we make. So when we had that first conversation with Health Emergency Management BC, they asked us to come to 7 locations and then said, oh yeah, and we've got like 3 more and we'd like you at 2. As you will know from the briefing notes that were circulated, we ended up going to 3 locations. 2 were arranged through Health Emergency Management BC, and the third one, so one of those was on the downtown east side, one of those was in Surrey, and the third one was arranged through our CEO, Karen McPherson, who's got quite a bit of experience with a charity in Surrey called Night Shift that provides hot meals, clothing, and other support to homeless people every single night of the week, 365 days a year, from 6:30 to 9:30. And we're supporting them and helping their team out as well. So that's kind of where the whole thing got started and how it got started. You will know, some of you, that we leapt into this. We did not follow a brigade chain of command, and we tried to engage people really quickly because there was a need to do so. From the statistics that have been presented to me, this is the only time that we can say statistically that we have saved 8 lives, and we did that between December 25th and January 12th. We saved 8 people. Those statistics would have been 8 people higher for the month of December were it not for our efforts, and that's something to be very, very proud of. So Did we go about it the right way? Probably not. Would we do that again? Probably not. Was everything that everyone did done with the best of intentions? Absolutely. So we've learned from that. When we launch some crazy pilots on short order in the future, we'll go about it differently, having the lessons that we learned here firmly in hand. But what we're doing is working. It's making a difference. It's adding capacity. And we've been really firm with doing exactly what we said we would do, which is add capacity and not take on the opportunity, for example, to take on, Drew, a washroom at Carnegie Hall at the corner of Main and Hastings downtown that nobody else wanted to manage. So a place, may I add, with one door in and one door out. We have said no to opportunities like that, and we will continue to do that. So that's my introduction for how did we get here, what we're talking about. And now on our agenda, we're going to turn it over to Stephen, who's going to talk to us about, give us an overview of the existing Narcan training, and then we'll move on to some other topics. So, thank you.
Well, hello and welcome, everyone. I'm glad that everyone that is currently here is able to make it to this wonderful presentation as well. As Provincial Training Officer, I wanted to just give you a very brief overview as to a little bit about training, more as to where to find training, but more along the lines of expectations of MFRs during a duty that is requiring naloxone added, and of course what you can expect from healthcare providers and what healthcare providers can of course expect from you. So what I wanted to be able to talk about is identify where you can get more information about intramuscular injections and of course naloxone administration, because we have a wonderful course that was developed originally by Keith Tyler and has been passed on to me to maintain in our online learning management system. Understanding the responsibilities of an AMFR when it comes to treating an opioid overdose. So just going to very briefly go into that. And I have some case studies that, or not some case studies, but we'll have some polls that we'll do beforehand just to kind of see how people would react. And of course, compare what an AMFR versus other healthcare practitioners or healthcare providers might do when it comes to treating an opioid overdose. So first of all, I just want to make sure I can plug our online learning management system. We have developed an online, we've developed a blended course when it comes to naloxone administration. For those that have never had a chance to be able to do naloxone administration, this would be part 1 of 2. So there's an online component and an in-class component that if you need some information as well, feel free to be able to email me. I'll be posting that in just a moment. For those that are healthcare practitioners and have experience when it comes to intramuscular injections and naloxone administration, I still encourage you taking at least the online portion, just so you can get a sense as to what other members of the St. John Ambulance community, particularly AMFRs, what they're being trained to know and, of course, trained to do when it comes to naloxone administration. And it's only about a 30-minute pre-read with some videos, so it's not too bad. So the website is go.sja.ca/campus. There is a YouTube video that is circulating around on how to get free access to the course. Very importantly, if you cannot access the course, if you cannot make an account into it, anything that would otherwise prevent you from getting into this course, please email me directly. So anything relating to technical difficulties with the online course, please email me at pto@bc.sja.ca. If you don't have a chance to write that down later, I can always repeat it at the end of the case rounds as well. So what I thought that I'd start with is some polls and some quick case studies. So for those that have only AMFRs training versus those that are healthcare providers, you might find some answers to be surprising, if not enlightening, but hopefully we can at least all end up on the same page. So I want you to imagine that you have this patient right here, that they have a history of opioid use, as in they have just used an opioid, such as fentanyl. They're unresponsive. You don't know what their airway status is. You know that they're not breathing, even though it's manually opened with a jaw thrust or some kind of airway maneuver. There is no breathing. Pulse is strong and regular. They're pale with some cyanosis mixed in, cool and clammy with no injuries. So what I want you to do is, there's 2 questions that will pop up. I'll do one first and then the second one, is what would you do, or what would you want to do for this particular patient? So I've got some interventions here that you may want to do. Now the next question is what would you want your partner to do? So think about what you would want to do, and then if you're working with a partner, what you'd want your partner to do. So I'm not going to talk about single response with this one, but just take some moment to be able to just answer the question. I believe the poll is going to pop up somewhere. I think one person answered, and so far we're unanimous with one choice. Okay, we've got a mix in there. That's good. Definitely think those two options are very, very good. And I'll give another 5 to 10 seconds or so. Looks like half the people have voted. All right, so I'm just going to close this poll right here. Okay, so it seems like 18% of you said you would insert an OPA or an NPA. 79% of you said that you would do artificial respirations with oxygenation, and 4% said that you would do oxygenation via a non-rebreather. So we'll talk about that in a moment. But what I'd like to do is apparently have trouble. There we go. Is now go on to the next poll. So now, what would you want your partner to do? So while you're doing whatever it is that you identified you want to do, what do you want your partner to do? So I'll give about 10 to 15 seconds on that, just to make sure that we're all on the same page. Ooh, we have a very nice mix with this one. Okay, so I'll give you 5 more seconds. Okay, so we're just going to close that one. So on the first one, as far as for what it is that people would do, again, we had about 18% of people say that they would insert an OPA, about 79% saying that they would do artificial respirations with oxygenation, and 4% said that they would use a non-rebreather with oxygenation. Now, as far as for what your partner would do, this is very interesting. 50% said that they would control the airway with an OPA or an NPA. 7% said they'd get their partner to do artificial respirations. 23% said that they would administer naloxone. 13% said oxygenation via non-rebreather. And, of course, 7% to intubate via advanced airway. So that's very, very interesting. So now, I'm going to be asking you the exact same 2 questions, but now we have this patient. So, again, same history, obvious opioid use in the recent history. So they just, again, had just used fentanyl, for instance. They're unresponsive. You know that their airway is open because there are signs of breathing with clear air entry. Their breathing rate, though, is approximately 4 per minute. They have shallow, regular breathing. So they have a strong, regular pulse. They're pink, warm, and dry, so this is a very recent event. And, of course, there are no injuries found. So same 2 questions, starting off with what would you want to do? And then what would your partner do? So we'll start with what would you want to do, and then what would your partner do? And we'll keep this open until at least 50% of the people have voted and give an extra 5 seconds after that. All right, we've reached the 50% benchmark, so I'll give you an extra 5 seconds for those last moments to come in. All right, and I'm going to close that poll. With very, very interesting results. Now what we're going to do is we're going to say, what would you want your partner to do? And again, we'll wait until we have 50% of the votes, and then we'll give another 5 seconds after that. So currently we're at 40%. All right, and we'll give you an extra 5 seconds to get those last-minute votes. Okay, and we're going to close it from there. Okay. So, for this round, hopefully everyone has a chance to see this. These are what the results that popped up with. 19% said that they would want to insert an OPA. 56% said they would want to do artificial respirations. 9% said administer naloxone. And 16% said oxygenate via a non-rebreather. So now, as far as what they want their partner to do, 32%, it was a 2-way tie with administer naloxone and insert an OPA NPA. 23% said artificial respirations by oxygenation, and 13% said oxygenation via non-rebreather. So we have two different types of mentality that when it comes to this, both of them going towards the same direction, which is both good. So it seemed like for the first patient that we had, the main thing was get them breathing. That was the main theme. And of course, help control that airway. When it came to the second one, it seemed like there was still leaning more towards getting those artificial respirations and still controlling that airway, but there was a lot stronger of an impulse to try and administer that naloxone into that patient. So let's talk about expectations. So in the online training, basically the main three themes of it are airway, oxygenation with ventilation with oxygenation, and the administration of naloxone. So when it comes to AMFR, every AMFR that goes through AMFR training and CPR for healthcare provider knows how to be able to use NPAs and OPAs. They know manual airway maneuvers, so they know how to be able to help maintain that airway. They're all trained in artificial respirations with oxygenation via bag valve mask and pocket mask. And whenever, regardless of the circumstance, if you have a non-breathing patient that has, or a patient is not breathing adequately, and they still have a pulse, the key is control the airway and get the oxygen into the patient. So you need to oxygenate with ventilations. So for us, basically for the scope of practice, we're just adding in the fact that you can now do naloxone. So as that's in this case the general dosage that is given within the course, 0.4 milligrams of naloxone every 5 minutes as needed, up to 1.2 milligrams. So basically it's airway and breathing control, following that with any other interventions now that the patient can be maintained. Now, when it comes to care of a patient with higher levels of training, I have an example here for scope of practice, for treatment guidelines for primary care paramedicine. You'll notice that it's actually the same. So again, maintaining open airway, adequate oxygenation and ventilation with the patient, and of course, the administration of naloxone. Now, when it comes to a higher level of care wanting to administer naloxone, I have personally seen it where someone is breathing adequately, so that case study number 2, where basically someone jumps in immediately with trying to administer that naloxone, but the key is making sure that oxygenation and ventilation comes first with airway control. Because if the naloxone doesn't work, then we might have just wasted some time when we could have been maintaining this person's basic vital signs. Important to know that for those that are PCPs, basically by the health authority, we are pre-approved for 1.2 milligrams of naloxone administration. So you already have, so even though we're not calling EPOS or a medical or asking for further medical direction, basically we're already pre-approved for it. So no problems with that. You can act to your full scope of practice with treatment guidelines. Already had a chance to be able to do the polls. So some things that I just wanted to be able to touch on, because if you're an AMFR, your ABCs are your big priority, and then you have time to be able to administer the drug. So if you are working de-paired or working with someone with a higher level of training, note that if their focus is trying to get that medication administered, always make sure that someone is doing something for that airway and oxygenation. So make sure that you can always go down to your bare bones basics with it. So that's just hopefully not to surprise you that that might happen. And for those that are healthcare providers, note that the main priority of course, AMFRs is making sure airway, breathing, and circulation is adequate. So note that they'll focus on airway and breathing to begin with. So if you wanted to jump on naloxone administration, you could, but note that supporting whoever is going to be doing the ventilations is always our key priority. Other things the health authority has asked us to do, note that we are allowed to do through the clothing administration. In the classroom, we are teaching a proper aseptic technique using the lateral thigh and deltoid as our administration sites. But the health authority, as a safety measure, has encouraged us to start doing through the clothing administration, just to make sure that we're not exposing ourselves to sharp hazards. Also, there's an excellent resource in the online course that is regarding towards the heart, which is naloxone and fentanyl education for the general public. There is a link in the resource section in the naloxone course, as well as you can just look up towards the heart. An additional document you would need to fill out other than your PCR would be the overdose response sheet. Unfortunately, it was kind of big to fit on the slide, so if you wanted to be able to know more about it, feel free to email me directly, or you can just go into the online course to the additional resources section. Other than that, the one thing that I want to make sure I can stress to everyone is, of course, just making sure that when you're dealing with your patient, regardless of level of training or experience, your ABCs are always #1 priority. And I've talked to advanced life support paramedics and nurses and doctors and other paramedics too. I'm just making sure that the patient has the adequate breathing and ventilations themselves is always our #1 priority. Because if you have that, then you have the time to administer naloxone. Otherwise, as far as for questions, I believe we're saving questions for the end. Mandy, feel free to be able to correct me if I'm wrong with that. But otherwise, I do plan on staying for the rest of the presentation in case there's questions that come up in chat. So you feel free to chat with me directly, or you can always have them verbalized at the end.
So we will save questions to the end because there will be a Q&A session, and then we'll have everyone, all the panelists on board so that we can all answer appropriate questions. So if you do have questions, feel free to type them into the question box, and I will stash them for later.
Perfect. And Mandy, feel free to remove my power as presenter as well, or if you need me to do that, let me know.
Thank you, Stephen.
Well, good evening, everyone. My name is Drew Burnett. I'm glad that everyone's able to join us for tonight. It's a privilege to be a part of this, and I'm glad that I was able to join everyone. So I'm just going to talk about, oh, one sec, make sure we're getting the right slide.
There you go.
Perfect. So we can actually go right to the next slide. So Jill already touched base on this, but we wanted to kind of just explain a bit further where we came from, where we're going, and how this all started. So obviously, as Jill was saying, in early December we were contacted, and so we started a night shift. That was kind of the immediate need. Night shift being in Surrey on 135A. And really, we found that we actually weren't utilized that much at night shift, more from really just from the aspect of they were happy that we were there because night shift staff, including the nurses, didn't have things like naloxone to provide, as well as the kind of the first responder aspect. And then right away we moved into the downtown east side. So the mobile medical unit, this is the unit that was used during the Olympics, is looked after by the Provincial Health Services Authority. And so what they asked is they didn't really know, this is all new to them, it's never been used in this, the medical unit's never been used like this before. And so they looked at what could St. John do. And so we started kind of, it was in December, we started as a kind of a meet and greet, if you will. So as individuals came up to the MMU, there's no waiting room. It's set up like an emerge type of facility, but there's no waiting room. And so our members were there to help, identify those that required medical need right away. And then it moved quickly into providing take-home naloxone kits. So people would come up and they would need a take-home kit, and currently our St. John members runs through what to do, how to administer the naloxone, and then provides them with a kit and signs it out. And from there, we've looked at in December, that was those two main locations. We moved quickly in Surrey from just doing night shift in the evening to actually being on the strip, I call it, 135A. It's a two block radius. And from there it was a bit more hands-on. So the members there are able to partner up with RCMP, BC Ambulance, or the street nurses. And really that's more of an interaction with everybody that's in tents, and so there they have the opportunity, they walk, they get to meet people, a lot of great conversations are actually had, and they get to check in, and so every hour or so they do tent checks, so they walk around, they make sure that everybody's okay in the tents, and from there, and so obviously on site is BC Ambulance and RCMP 24/7, and so we're right there with them. And so it's a very safe perspective from that. And so that's kind of where we started in early December. We did have a plan, as Jill was saying, they were looking at 7 locations. We didn't have any of the other divisions that really were interested at that point kind of moving forward. So we really wanted to focus our attention, and obviously it's a lot of volunteers. We were looking at Surrey being a shift all day and all night. So we really wanted to focus our attention and not burn people out. So we focused on Surrey and downtown east side. And then moving forward, we're just starting in Victoria. Victoria's been at a shelter there for a couple of years already, and so it was easy for them to jump in from an naloxone administration perspective, and then we're also in the next couple of weeks going to be moving into another shelter there to help out. So that's kind of how it all started and where we are, but I think Jill touched base on a lot of that. And that's, I think, it for me.
It's Q&A next.
Q&A.
So we're going to move on to the Q&A because I know there are quite a few questions there. And to start, if you have any questions, just type it into the Q&A box. Meanwhile, we'll have some commonly asked questions that has been emailed to the Drew as well as Stephen that they're going to start answering first to begin with.
Okay. Yeah, I think.
And Adam is online too. Yes.
Dr. Adam Lund is also with us, and we're very glad to have him here with us tonight, and he'll be helping to answer the Q&As as soon as he's unmuted.
And Adam.
I am unmuted.
Stephen.
We hear you. We hear you.
All right, so we have Stephen, Adam, Drew, Jill here, and they will answer all the questions you have, assuming that time allows it.
Yeah,
so if I may for just a moment, it's Adam here. I'll just declare my multiple hats. I happen to be one of the associate medical directors for the mobile medical unit, so I've been involved in the background conversations and planning on the PHSA side. And additionally, I am an EPOS physician for BCEHS, so I'm familiar with the protocols, the call-in, and sort of the patch support model right there. And then from the St. John perspective, I've been a member since I was about 12, and so I've gone through the different ranks at different levels with Division 59, 998, Tri-Cities, and I'm now the area medical officer. So I will, if I need to switch hats, I'll identify the perspective I'm answering the question from, just so there's no organizational confusion.
All right.
Great. Sure. So one of the questions we've heard a lot asked was, which health authorities have approached St. John Ambulance to provide these services? Why are they taking this away from paid professionals, asking for volunteers, and would we be scab labor? So we just wanted to be clear that the health authorities that have come forward, so as Jill was saying, the initial request was from Health Emergency Management BC, and so because this fentanyl crisis was declared an emergency, it goes to Health Emergency Management BC, who originally is basically the connector, if you will, and so they reached out. The health authorities that we have spoken to date is obviously the Provincial Health Services Authority with the Mobile Medical Unit downtown east side, but we did also speak with Coastal Health, which looks after downtown as well. We've spoken with Fraser Health Authority, and we're actively communicating and looking at where we're going to go moving forward, as well as Island Health over in Victoria. We've been talking with them. So far, those are the only health authorities that have come forward. I've heard from a lot of members from the Interior as well as the Yukon about doing something there, and currently we've had nobody approach us. We've had nothing on the radar that there's necessarily need there. From the perspective of taking work away from paid professionals, so we've been in communication with everybody that we're currently with on the street, and what we can say is that we're actually not taking any work away. So from our perspective, with St. John Ambulance, if we attend a call, we're still notifying BC Ambulance, that kind of idea. So actually what it's turned into is more of a partnership. And you'll see that in one of our pictures actually coming up with Surrey in particular. We actually work hand in hand very closely with BC Ambulance, which has been a huge help. So I think that kind of helps us. And so another question, is there a written agreement between St. John Ambulance and the Health Authority outlining what services we will be providing? And do they know what we are not paid? Do they know that we are not paid employees but volunteers? So yes, obviously we're very proud, first of all, that we are all volunteers. I think it's obviously a key aspect from a St. John Ambulance perspective. And so we take pride in that, and that's the first thing we say, is that we are volunteers. Because the time that the volunteers have given it's been phenomenal. So written agreement. So what we have done is we've provided the health authorities exactly what the scope of practices from an emergency medical first responder. We've been very clear with what we can and cannot do. And the key thing here is that we're not, we came into this being very open and transparent. And again, we're not there to replace anybody. We're there to assist them, and the abilities that our members have currently with doing artificial respirations, for example, is actually something that's been missing. And what we heard from Surrey, from Fraser Health Authority, is that street nurses were arriving on scene and people were doing CPR on individuals that were sitting up. Or they were trying to bag valve mask somebody on the ground and didn't have a proper seal and actually was never even working. So, we were able to at least come with that help. Why is St. John Ambulance trying to become more like BC Ambulance when we have spent years trying to differentiate ourselves from them? We provide a completely different service. Well, what I would say to that is we're not trying to be more like BC Ambulance. I think, for us, this really rang true to St. John Ambulance's mandate to help our help the communities. And I think it seems to many like we may be doing some BC Ambulance type stuff, but to us it's really serving the community, and the work and the skills that our volunteers have is something that we felt would be able to be useful and helpful in this situation. Why are you asking PCP and EMR responders when our malpractice insurance does not cover us? So I think we've answered this quite a bit throughout, so I'll just be really quick that we do have insurance for the training of naloxone as well as the administration of naloxone, and of course Jill is just announcing that National has now agreed to pick that up. Since we are volunteering our time we are not covered by WCB, so there's been a lot of questions about insurance and about coverage. So no, you are not covered by WCB because you are a volunteer. And there's been some confusion around that. So St. John Ambulance does have insurance for their volunteers, and we are working on, we do have a document, and we're trying to get some clarification from National so that we can actually share it with you, just because we don't want any misinformation. So we are working on that. So the insurance coverage will our cover our medical and living expenses. So within our insurance, there is kind of a price, if you will, and unfortunately, I'm sorry, I don't have it with me, but we have shared that information in the FAQs, so you can check out the FAQs, but we have coverage up to $1 million, that kind of idea. And there is also a high risk of contracting infections that can be life-altering. That is true. So one of the things that Dr. Lund might speak to is in the event that you do come into contact with bodily fluids. For example, we had a situation in Victoria where somebody in close proximity sneezed all over somebody's face and that kind of idea. It would be the same standard in the sense that you go directly to an emergency. Do you want to go directly to an emergency department to seek medical care there and document, and we again are working on a documentation that we can send out that actually kind of clearly lays that out. And maybe Adam, if you're on the line, do you want to speak to that a bit actually about the protocol that we want our members to follow?
Yeah, I think we're still waiting to see what comes back with respect to policy, but the situation is in the emergency department, if you came in as somebody who had been working in this environment, you would be handled through the same algorithm that any healthcare worker from the community would be handled. And essentially an assessment of risk would be done based on any known information about the source, if it's known, and a history and physical is done based on your own risk factors. And the vast majority of times, and perhaps Jonathan, who's on the line, can speak to this as well, the vast majority of times exposures to body fluids are deemed to be low risk by public health, and the need for intervention is very, very low. So whoever was submitting the question, there's a statement in there that hasn't been challenged. There's also a high risk of contracting infections. I would argue that the risk is low. Is it possible? Absolutely, it's possible. But with our standard approach to universal precautions and due care and attention, the risk is low.
All right. Stephen here. Very quickly as well, for those that do want to have some information on it, in the additional resources section in the online course, it has a brigade, or it has some documentation that might help you when it comes to what to do if your clothes get contaminated and things like that. So it's worth checking out. All right.
Maybe we can move on to some questions that aren't around insurance and rather about the medical portion of it, and take advantage of the fact that Dr. Adam Lund is with us.
So we actually will move on to the questions that are in the question box right now. So it's Mandy, by the way. I will read out the question and then open it up to all the panelists around to answer the question. So the first question is, can appropriately trained members titrate?
I think that I can answer that one. So for those that are trained to be able to titrate medications, again, just as Drew was saying, that when it comes to naloxone administration, if you've been trained to do naloxone administration in a particular way, then you're covered to be able to do that. My big question, though, is if the person doesn't have an IV in them, then I would recommend not titrating, simply because if you do a lower dose than the 0.4 milligrams, then you're then you're going to be, and if it doesn't work, then you're just doing multiple needle attempts, which basically the patient is now becoming a pincushion. So my recommendation would be is that if you are titrating, it's with an IV inserted so that you actually can properly titrate without causing additional pin pokes to the patient.
Adam here. From my perspective, I think that it's a reasonable question, and if you are coming from a healthcare professional background, and as Stephen has said, if you have already gone beyond and have IVs and so on started, then that's probably a separate conversation. I would probably err on the side of trying to approach something that reinforces the basic protocol for everybody that's around you. And we're talking about an emergency response, somebody who has an altered level of consciousness, perhaps they're not breathing, perhaps they're in full arrest. And so the quick and available route is the IM dose, and in that circumstance, the finesse of titrating is probably not as valuable. If you have somebody who in a hospital setting has had an accidental excess of a narcotic given perhaps in the context of a procedure, then choosing a finesse dose is a finishing touch, but I would probably encourage the conversation to be around reinforcing what we want not just our own members to be doing, but also the bystanders, the patients themselves who are going away with take-home naloxone kits. The more we reinforce the exact same message, the exact same timing, dose, and route, I think the more we strengthen a foundation for how we're approaching this unique situation.
All right, the next question is, has this problem started from overprescribed opioid medication, and what do the users think they are taking?
So Adam, I can take a swing at this one if you like. It's an excellent question, and it's one that's quite varied. So part of the question is, why do people get addicted in the first place? So one aspect of that is certainly some people do enter that pathway because of prescribed medications, because of chronic pain, and developing a dependency based on initially appropriately prescribed medications. And for some people, when the time comes to try to move away from opioids, which are the morphine-like or the heroin-like medications, and to try to get down to more basic medications, they experience symptoms of withdrawal. And at some point, if their healthcare provider, out of good interest, thinks that they should no longer be taking opioids, people will sometimes try to get supply from other people who have it prescribed. And at some point when that's not available, then moving into the illicit sources becomes an issue. So for the people who have come into that pathway from a pursuit of pain relief approach, they sometimes are trying to get what they believe to be a redirected appropriate supply. So some of the illegally sold substances do look like pills, they look like oxy, they look like some of the things that people hope are replacing what would have been prescribed. The reality is it's much cheaper to use other products and then to use small doses of fentanyl, or we're hearing about carfentanil now, where people can get a similar feeling of pain relief, a similar high, so they think that they're getting the effect they want. A whole other population is people who get into the use of drugs from the perspective of recreational use, and certainly many of those people find themselves very far down a road they never wished to travel. And so people in some cases are ingesting things like pills or powders. Sometimes people are smoking, and so they're inhaling a burned version of the product. And then at some point people may cross over into the pathway of injecting. So in that case they're taking, sometimes they're dissolving down or melting down pill or powder products and then injecting it for the most efficacious effect.
Perfect. And the next is, what is the opioid crisis long-term expectation?
So it's Jill speaking, could I ask that maybe Adam, you answer this from the medical perspective, and then Drew could chime in from the St. John perspective, because we're not sure which perspective the person was asking the question about.
It's an excellent question, and I don't think people really know. There's a new player in town. And what's happening here is, if you'll permit me, we have to do just a little bit of drug dealer math. I know that we're not in a way that everybody can answer their questions or show their understanding here, but virtually I want you to raise your hand if you've ever seen a movie or a TV show where they show a kilo of some drug. It's always some Hollywood person opening the trunk of a car and there's a bunch of these tightly packaged kilos. So imagine that. If you were trying to be an importer of heroin and you wanted to bring in a kilogram of heroin, you can imagine that multiple kilograms of heroin takes up a heck of a lot of space. So if you're a drug dealer and you're doing good drug dealer math and you figured out that there was a product that was 100 times as potent, so instead of bringing in 100 of those kilos, you could bring in one of them and then cut it down and get the same effect for your customers, you would think that, well, from a shipping, handling, and receiving point of view, that's pretty practical. And then take something like carfentanil, which is another order of magnitude more potent, and your drug dealer math gets really, really, really good. The problem is there's multiple steps of handling along the way, and if somebody did a really good laboratory quality job cutting it down to that 1 in 100 dose, we wouldn't be dealing with perhaps some of the problems that we're dealing with. But the reality is that the chain of handling is an imperfect process, an illegal, unmonitored, and illicit process that has profit in mind, and we're not seeing consistency in the dosing. Some people have said, well, why are these people killing off their customers? Which, whatever, I don't think that's not really a productive comment, but I've heard it a lot of times. Certainly that's not anybody's, that's probably not their intention, because that's not the intention in any kind of a business environment. The issue is that people are getting a higher dose of the effective narcotic than they're intending, and they're going down the pathway of what we would call pathophysiology. They're decreasing their respiratory drive, they're becoming hypoxic, low oxygen, they're becoming hypercarbic, high carbon dioxide, which makes them acidotic. That causes the further decreased ventilation, further dysfunction, eventually dysrhythmias, and that's the pathway of arrest. And what we need to do, and what Stephen very clearly emphasized, is we need to reverse that pathway with opening the airway, ensuring we have ventilation, ensuring oxygenation, and if the person's heart is no longer perfusing, we need to help them perfuse. And one of the things that we can add to our algorithm that we already know very well and practice all the time is there's a space for this new thing called naloxone, which will help us by getting the patient to start to participate in their own resuscitation. They'll start to come back with some of their own respiratory drive. But it's not doing what we do for them. We still need to do all the things we've always done for someone not breathing or somebody without a pulse. All we have now is a pharmacologic helper that will get the patient to participate in their own resuscitation.
So from an organizational perspective, I'll start off with just saying that one of the key things that we are always thinking of is obviously our members and the impact of volunteering every day, and then also as we move closer to summer, we start to get busy with community service events. So that's something that we always have at the front of our mind. Organizationally, we have decided that we're going to follow this through to the end of 2017 if we're still required. But what we are seeing from the health authority perspective is they're now approaching us and saying, look, our numbers are decreasing from an overdose perspective, and so we really are looking for more of a surge protection. So what their stats are showing is 5 days before Welfare Wednesday and 5 days after Welfare Wednesday is when they see the most a spike in overdoses. And so we are talking with Fraser Health about decreasing our time, so we're not necessarily there every day, but being there when data and things start to show that there is going to be a spike in potential overdoses. And same with downtown. Already the mobile medical unit has decreased their hours of operation, and so we've in turn shifted our response to only being there evenings during the week, and on weekend we're there in the afternoon and evening. So that's currently what we're doing. We're going to work with the health authority. We're not, as Jill was saying, we're not going to do our own thing. We're really going to see where we can in a support capacity, but also ensuring that our members are safe and that their well-being, both mentally and physically, is looked after.
So the next question, what is the role of SJA for treating and discharging back to the street versus needing to call EMS for transport to hospital for assessment? Who makes that decision?
Adam, do you want to tackle that one?
Sure. In this case, if you've got somebody who has a decreased level of consciousness, decreased breathing, etc., we are going to be activating EHS very early on in our algorithm, so there really isn't or shouldn't be a decision at the end of the chain about whether or not to involve a higher level of care. So if we're actually getting through a full resuscitation, giving Narcan, waking somebody up, and then having a conversation about not going to the hospital, it's possible that I think the feasible scenario there is a very long and delayed response from BCEHS. So, two-part answer. The first part is we should be involving BCEHS and we should be involving a higher level of care with an intention to transport for all of these patients where we're participating in ABC intervention or where we're giving naloxone. There is a secondary issue here, which is a very common one. When I'm on call for BCEHS, I get 4 or 5 calls per shift from paramedic crews who have been involved in the care of a patient who had an opiate overdose, who were actively resuscitated on the scene, given naloxone either by a bystander, by fire first responders, and sometimes by the BCEHS members themselves. And at a certain point, some patients will get up and they'll say sometimes not nice things and say, screw you, I'm not going to go to the hospital, and they want to leave the scene. Medical legally, that's a difficult situation. My recommendation from a St. John Ambulance perspective is that BCEHS has supports. They have a legal way of documenting those kinds of interactions, and I think that it keeps it simple for us to say that our goal is to have BCEHS involved. So I will identify the loophole that's probably going through some of your minds. What happens if BCEHS is delayed? We've acted on a patient, we've given naloxone, they get up, they say some things, and they say either thank you very much, you're so kind, or they say something rude to us and they want to leave. Are we going to try to keep somebody at the scene until authorities arrive? My answer to that would be, of course not. Absolutely not. We're going to do our very best to say we're worried about you, we're worried that the naloxone could wear off before the underlying drug, but if the person is determined to walk away, I don't believe that it would be in anyone's best interest for us to get involved in trying to detain people. Document as best you can and report up the chain of command about that interaction.
Okay. The next question is, are we as MFRs allowed to use Narcan at regular duties? And if so, is there going to be universal kits for all the divisions?
Great question. So right now, what we've kind of rolled out. So our naloxone coverage is what we've specifically, what we as in BC Yukon have I guess purchased, and the insurance here is only stipulated to the actual fentanyl crisis response that we're delivering. So Lower Mainland, Fraser Valley, and Victoria. But as Jill was saying, potentially at some point this is going to be rolled out nationally. I think before we move to the direction of saying any event in BC Yukon you can deliver naloxone. We really have to look at it internally at the provincial staff officer level around, where do we get the drug, how are we paying for the drug. Currently, the naloxone as well as the syringes are provided to us by the health authority, and it's specifically for the fentanyl crisis. So we really need to keep in mind, if we provide naloxone across the province, where are we going to store it? How are we going to store it? And of course, there's certain rules that we have to follow. So at this point, Lower Mainland, Fraser Valley, and Victoria for the fentanyl crisis on its own.
To follow up with that question is, what happens when we are treating a patient as MFRs and a member of the public shows up with a Narcan kit and thinks that we should use it?
Adam, you're a great person to address that question.
Sure. I think there's an issue here. We can answer medically or we can answer organizationally. Right now, I think that the leadership team involved in this initiative has moved the organization forward a whole bunch of steps. So to try to press on and sort of push our advantage a couple of extra steps right away to say, let's have it in all our kits and use it at all of our events, until we've really buttoned up and demonstrated the efficacy of what we've done so far, organizationally, it might be one of those things where we should make sure that we're walking steady before we run. But having said that, I think it must be apparent to everybody on the call that the fentanyl crisis does not have a geography. So we could have people who have an illicit substance at the Abbotsford Air Show, for example, and if somebody in one of the public bathrooms is found down with evidence or with a bystander who, a friend, for example, who says that they know that they used an opiate and the person has a respiratory rate of 4 and they're cyanotic, what would we do in that situation? If by the time of air show we're not having that on event, although I imagine that's a possibility that we might have that, but if we didn't have it and that friend, that bystander who said, I know that this person used an opiate, and by the way, pulls out of their purse, here's a take-home naloxone kit, we would certainly not be in a position, I think, to refuse that person from using it. And I think we probably, when we get into our working orders for the particular event, we're probably going to have to tackle that in terms of what would we do. Are we going to supply it ourselves and use it? But I think, and I'm going to maybe be stepping outside of my authority with my answer, in the event of a medical emergency where we have someone with a good story and we have an available kit with a person who's had training, I think in those circumstances I don't want to be in an organization that has no ability to do what's right for the patient and then debrief and learn from it afterwards. So please don't I don't have the authority to tell the 52 people on the line to go ahead and use it, but I think the issue here is that this is a new problem. The rules were written at a time when we didn't have a fentanyl crisis, and the fentanyl crisis is not just in the downtown east side or Surrey or Victoria, it's anywhere people are abusing opioids. So I think that we're going to be able to draw lines around what we're doing right now, and the success of this initial program will allow us to do more. And if we do this well, our ability to take on other protocols outside of naloxone will be much more supported because we did this right and we documented how well and how successfully we rolled it out. So it's not that we don't want to go there. I think that as an organization we're going to get there. Let's just take the steps in order so that we can do it and be well supported and not have a foul up and have it taken away.
It's Jill speaking. Adam, thank you so much for that great response. I would add to it to say that the discussions I've had with the National Director of Community Services is that we're looking to position this much the same way they did when they were addressing the use of EpiPens and people providing their own EpiPens and you know, us being able to administer that if somebody provided that medication. So those conversations, as you rightly alluded to, Adam, are still happening, and we're going to work towards that. But I'm just so heartened by the fact that common sense has really prevailed up till now, and I have every reason to expect that it will continue to go in that direction. And I think, you know, Mandy, we're just looking at the time and being respectful of people's time. I think we have more questions than we had time for tonight, which is a good thing.
Yeah, so unfortunately we won't have enough time to answer all the questions. I do have one that I feel many people can benefit from. So we'll do this one last question, then we'll wrap up. And for the questions that we're not able to answer tonight, we will email you individually and answer all your questions.
Yep.
And we'll go from there. So the last question is, what is being provided to members in terms of critical incident stress management?
Oh, what a fantastic question. Drew, do you want to speak to that?
Definitely. So again, this was key for us as we moved forward to ensure the mental well-being, physical well-being of our members. So NAHAM, who looks after the critical incident stress management team, has been working closely with us on that. And so basically, currently, what we have is critical incident stress management has a course coming out, which will benefit everyone in February. So if you haven't signed up, head to the Better Impact system, and you'll see the course for February and sign up there. There's a little Better Impact plug. And but besides that, the critical incident stress management team is reaching out to all volunteers who have been volunteering for the fentanyl crisis, and of course, they are available 24/7, which has been a huge help. But I think the key thing is that we're not necessarily waiting for people to come to us. NAHAM is doing an amazing job in reaching out to volunteers to ensure that they are doing okay, which is key. And of course, we have leads at each site, and it's their role as well as to ensure the safety and the well-being of those members. And so they're also watching to look for signs and making sure that people are doing okay, and if they need to take a break, they take a break type of idea.
There is just so much to be proud of with regards to this pilot and how people have come together, and all the different aspects of all the different things that we can do are coming together and being exercised. So that's really exciting. And just as a last comment from me, before Mandy wraps it all up for us, I just wanted to speak very quickly to what's going to happen in the next 4 weeks and what you can expect. So Drew already alluded to part of that. We're doing a review of our involvement and our activities, and it looks like in our conversations that what's going to be required as the immediate need dies down a bit, that what's going to be required is more surge support. So that's the days leading up to welfare checks being issued and the days immediately after, where they've noticed through statistics that things are really peaking. So rather than having, like 30 days of the month that they need us, it might just be that it's a matter of 7 or 8 shifts that we're trying to help with. And we'll keep you posted on that. And then the second thing that's happening is, of course, we'll be going through, undertaking a review of the training materials, and we've already had some great contributions from Dr. Adam Lund on that, and we'll be incorporating those. And I think as you go forward, you can expect to see this was version 1, then there will be version 2, and we'll continue to learn from you, and we'll have version 3, and I bet by the summer version 4. That doesn't mean that what we did originally was wrong. It just means that we have a great group of people committed to making it better. So stay tuned for that.
Yeah.
Awesome. So thank you everyone for coming today, and thank you Joe, Drew, Adam, and Stephen for joining us tonight too. So our next case round will be on February 22nd. It will be on the new updates on spinal precautions, and it will be done by Wakey, who is our aerial training officer in the Lower Mainland. I understand that there are quite a few new members joining us for the first time tonight. So if you're interested in joining us each month, you're welcome to send me an email at sjafacilitator@gmail.com, and I'll add you to the email list. Also to remind everyone, these sessions, you're eligible to use them for your EM, ALB, CME hours. So if you're a paramedic, EMR, ACP, and whatnot, you have to complete a survey after the session, and then I will send you all the information for filling out for your CME hours. Also, very exciting news. For the first time, we actually will be able to use this SE hours for MFRs too. So if you have been with us since last year, you can actually backtrack. So you just have to, again, contact me, do the survey, and I'll talk to your DTOs, and we'll have more process and more information coming out. And so if you're here tonight too, you're also welcome to use this for a CR, for its SJA. And lastly, Drew mentioned the FAQs earlier that will be shared via email for everyone. As well, for questions that we're not able to answer tonight, we will email you individually with some response, so you're not left hanging. So we'll stay online for a few minutes in case there are any last-minute questions that you can type in the question box, and I will stash them. Again, thanks for joining us tonight, and have a good night.
Thank you so
Thanks,
much, everyone.
Thanks, everyone.